The first talk will be given by Corey Walker, and he'll be talking about the challenges of the aging spine, frailty, osteoporosis, and sarcopenia. Oh, shoot, you're moderating.
Thank you so much for having me. I really appreciate it. And this is my first year attending this meeting. It's been really nice. So this is a real honor and something that I'm really kind of passionate about. And I think that is going to set the stage for all the great talks that are to follow. And we're really going to be talking about how do we assess these patients who are getting older and older and older in our clinics and deciding whether they're good surgical candidates or not. Here are my disclosures. So we heard all day yesterday all the amazing talks about things that we do in the operating room that will change the trajectory of our patients' outcomes, tethers, getting the alignment right, spinal pelvic fixation, et cetera. But there's so many things that we don't have control over. And, we had a great talk yesterday about PJK from Mike, and it was just like, you look at all the things that we've implemented and tried to do, we really haven't been able to move the needle a lot. And I think a lot of that is our assessment of these intrinsic patient factors that we don't have control over, or we do have control over, but we're not doing anything with. So one of the things that's come up time and time again and has grown in all of medicine, but particular in our spine literature, is this concept of frailty. And I think it gets thrown a lot around, and so I'm going to kind of discuss this a little bit because I think the idea of frailty is, in our world, your patient's tolerance for this immense trauma that you impose on them doing an operation. But frailty in other categories really is a phenotype and was described early on to describe older patients in nursing homes who were, at risk of death and loss of health span and all these things, and kind of composed of these 5 core elements. And then this guy, Rockwood, who's a gerontologist, described this concept of trying to quantify frailty. And he did something really brilliant. And he figured out that if you could basically count the number of patient health factors, and if you have enough that you take into account, it doesn't really matter what they are, the relative number of those health factors is strongly correlated to a quantifiable amount of frailty. And so this was called the deficit accumulation model. And this really served as the birth of a huge field of frailty indices that therein became super popular across all areas of medicine. And in our own deformity world, Chris Ames and the ISSG, and actually UCSF's own kind of product here was this adult spine deformity frailty index, which used this exact accumulation model concept, but with spine-specific things, as you can see here on the left. And basically, you just count these. There's no weighting to this. It's just you count the number of deficits that the patient has, and this strongly correlated to clinical outcomes that they looked at, which were pertinent to our patients, PJK, reoperation, pseudo, et cetera. And they categorized these patients and showed statistically significant differences. The challenge with this in our clinical practice is who's going to go through every single one of these and put a check mark in your clinic. And a lot of the inputs here are based off of the SRS score. If we don't have that available, or we don't regularly collect it, or a patient do it, then we're at a loss and we can't use this. And moreover, the question is then, what do you do with a number 16 versus an 8? It's all relative, but you don't really, it gives you an idea, but it doesn't give you an actual answer. What we've been working on with some of our computational scientists at Cedars is looking at patients and the data that we have readily available in the EMR. So basically Epic-based data, and seeing if we can just take this stuff that's already there and predict outcomes. And basically establish a frailty index with machine learning, with stuff that we don't have to go take out of a chart and add up ourselves and put together. And we've been able to really look at some pretty reliable outcome adverse event metrics and prove that. And if you really then go back and look, we just did a comparison study. Okay, how do I do some of these hospital-based frailty indices? There are frailty indices that are based on the electronic medical record where you don't need to do this other stuff, how well do they do against, typical machine learning? And actually, the answer is they give you some indication, but their predictive value is a lot less in a spine surgery patient. And if you actually decompose the elements of each of these frailty indices and run them through a machine learning algorithm, it does better than if you just use it as a straight frailty index. And it's because all the things that go into these measures, they're not linear variables. They have, intrinsic relationships with each other, and machine learning tends to do a better job at predicting that. So I think as we go forward and we look at this concept of frailty, probably what's going to happen is it's going to morph into more of a machine learning predictive analysis based off of algorithms and patient data that's already available, rather than us sitting in a chart, counting deficits. For spine surgeons, we also know that there are direct things in the aging spine that contribute to outcomes and correlate strongly with frailty and back and forth. Specifically, we know that poor bone health and muscle health impact outcomes. Bone health, obviously, for several reasons. It affects the strength of our fixation and our ability to correct. It basically is related to our ability to resist fractures at our junctions. And there's a part that we don't really capture well at all, which is bone physiology and bone healing, which refers to the part that contributes to pseudoarthrosis. And we know some people just don't heal. And things like smoking and nutrition and other things can affect that. And simultaneously, sarcopenia has been studied extensively for two reasons. One, it serves as a surrogate biomarker for frailty. So people grossly look at sarcopenia as a means of assessing patient frailty. But also, as spine surgeons doing these long segment constructs, the muscle tissue envelope around the spine is immensely important because it has to do with our compensation. It has to do with our ability to withstand intolerances and getting the perfect alignment. And so we all know that some patients have perfect alignment post-op and they still fail, right? And so we also know there's patients who we didn't really do that great of a job getting their numbers right, but they're still doing well because they have all the muscle compensation. So studying these things directly is really important. But these disease states are probably very strongly overlapping for several reasons. We know that in large population-based studies that the two coexist, and there's strong relationships between the muscle and the bone from a physiological standpoint. There's endocrine factors that affect both. There are paracrine factors. The muscle actually inserts onto the bone, and there's crosstalk between the two elements. And there's, a hallmark of both diseases is fatty infiltration. It's actually something that we quantify when we measure some of these things. And so obesity, which is a huge problem in the United States, probably contributes. And so all of these things come together. And to add insult to injury, there's probably a genetic component to the coexistence of these things. So what I would suggest is that we really start to think about these things in a lumped disease process rather than just purely in isolation. So we talked a little bit about assessing bone health. And here are guidelines from the CNS from a few years ago. And the reality is that we don't really have a lot of guidelines at all. This suggests that we look at vitamin D, DEXA scores, and CT Hounsfield units with a cutoff of 97 in their recommendation. What we do know, and this was brought up yesterday, is if we do get people on anabolic therapies, and this was shown really well with the Columbia group and Zishan and Lanke, that if you do treat people appropriately with anabolic medications, they actually do as well as patients who have absolutely no osteoporosis and better than the patients who have osteopenia that's untreated. So we have effective therapies, but getting people into that area is the challenge. And the reality is that we don't do a really good job of detection with current methods. So Ben Elder is at Mayo Clinic. He's one of the kind of smartest people in the room for this sort of discussion. And they did a really nice study that's not really cited enough, but they looked at the different ways of evaluating bone health. And they actually put together a kind of a linked assessment of bone health to see how well they could predict osteoporosis using FRAX scores, trabecular bone scores, DEXA, CT Hounsfield, et cetera. And actually what they showed was striking is that DEXA only accounted for about 25% of the osteoporosis. So if you use DEXA alone, you're missing 75% of your patients We do. We measure Hounsfield units. Well, Hounsfield units cover about 37%. So we're missing the boat on a lot of patients. It was brought up yesterday. What do you do about the patients who have osteopenia with a 2.2 T-score, their femoral neck? Like, the stuff they're not going to get paid for. And I think we're going to hear some good talks about treatment of osteoporosis and managing these patients later. So I'm not going to get into it. But the reality is that our current metrics and methods for identifying patients are lacking. Similarly, sarcopenia has been studied extensively. This is borne out in oncology literature and cardiovascular disease. And there's this European working study group that's like the authority on sarcopenia. And they've met a couple of times over the last decade. And their recommendations are that we define sarcopenia based on muscle strength, muscle function, and basically muscle size. And there's different ways of doing this. You can look at strength with things like grip strength. You can look at physical function by how fast they get up out of a chair or do different tests. And then you can quantify muscle and the actual muscle bulk and quality. And so you can do that with things like DEXA. You can measure appendicular skeletal muscle mass index. You can use body water composition with bioelectric impedance analysis. Basically, some people have these in-body machines in their offices to look at water content, which is basically a surrogate marker for body fat percentages, and that can give you an idea of sarcopenia. And then we can do like we do with Hounsfield units and make opportunistic assessments with available imaging that we already have. Obviously, the oncology literature has led this because every one of their patients has CT chest, abdomen, and pelvises, so they can very readily assess visceral fat and fat in the different compartments of the paraspinal muscles, psoas, and typically, this is assessed in the mid-lumbar at L3 or L4, and you can both measure muscle size with cross-sectional areas or volumetric assessment, or you can look at fatty infiltration and use, there's kind of categorical schemes for measuring that, like the Gutalier score, which is a 5 level, kind of qualitative assessment of the fat in the muscle, or you can actually use machine learning things to actually measure this for you. But the reality is in sarcopenia, there is no consensus on what is the best way to measure sarcopenia. There's all these different types of ways to assess it, but no one really knows how to use this clinically because all these different ways of looking at it and different clinical outcomes in every study shows something else. And for our patients specifically, paraspinal muscle fatty infiltration and muscle health doesn't always directly correlate to other global measures of sarcopenia that people are measuring. And this is a great study out of HSS that looked at different types of sarcopenia evaluations. And the muscle ones that we care about for our soft tissue envelope don't always necessarily line up perfectly with what we see in other measures of sarcopenia. So, from our standpoint, every study you see shows that sarcopenia is related to the clinical outcome that they want to look at, and there's some sort of correlation there. But we really don't know how to use or implement this in our clinic yet because there's all these different varying definitions, and we need to do more work to kind of look at specific spine outcomes and figure out what are the best measures that correlate to those outcomes. And that's something that we need to get better at as a field. If we're looking specifically at PJK, which of these measures of sarcopenia is most strongly correlated to the outcome? Which of these measures is most correlated to global outcomes? So there's a lot of work that needs to be done. Now, some steps moving forward in the same way with the machine learning. This was a study by John Shin and the MGH characters that did the metastatic oncology study looking at survival, just like all the other oncology studies, and they were able to show that they were able to not only segment automatically to L3 based on a CT, and then they were also able to simultaneously measure the sarcopenia based on a CT chest, abdomen, pelvis, and then quantify that, and you put that into an algorithm that correlated to survival. So this is a really good step forward. I think this is something that we need to kind of mimic and model. This is a study that was just published last month in Spine, and I think this is another attempt. This is a group out of Asia that looked at posterior lumbar interbody fusion subsidence and predicting that based on sarcopenia and this MRI-based osteoporosis measurement, vertebral bone quality score, which I have my own opinions on, but they were able to put these things together and come up with a predictive outcome that strongly correlated with the presence of subsidence. And then actually they did a really nice thing. They open sourced a calculator that, you can use in clinic that might help you predict that. And I think this is kind of a move in the right direction. There's also this concept of radiomics, which is that, we're putting all these manually measured or even machine measured inputs into a data set, but there's probably features of imaging that we already have that may be predictive that we don't even know about, and we can use unsupervised learning and an analysis and study of these things to predict bone quality and sarcopenia and probably correlate to outcomes. And so we need to continue to develop that. But here's an example of doing that for osteoporosis using CT scans and coming up with some ways to use the machine learning itself to figure out what's the important part of the imaging that is actually most indicative. And then you can therein combine that with clinical outcomes to actually even further boost your predictive analysis. So this is where we're going, and it's really exciting. Our involvement with the Scoliosis Research Society, and I know Joe's part of that, and Alekos and others, and Chris. And basically the idea is to highlight where are we going with all this stuff in the future, both from the standpoint of osteosarcopenia, but also biological clocks and assessing tissue markers. And it's really exciting, but we have a long way to go. And we as scientists and surgeons at the same time have to be participatory so that we get the right direction hit here. And so this complex of interplay of all these things needs to be really looked at by us for spine-specific outcomes so that we get the involvement of surgeons who care about the right things, and we're not deriving these things from oncology literature or cardiovascular literature or whatever. So it's an exciting time, but we have a lot of work to do. I think machine learning is going to really help us. And, again, thank you for the opportunity to speak today. It's a real honor to be here, and I'm looking forward to the rest of the talks.
Thanks, Corey. That was awesome. I think we do have a few minutes for questions if anybody wants to jump in.
Great talk. Thanks for sharing. Do you have a problem? Like we have a problem if the DEX is normal, even though all the other parameters, maybe the Hounsfield units are bad and things like that, to try to get care for the patient's bones. Is that a problem for you guys as well?
Yeah, and I don't want to step, because I think there's going to be some discussion about treatment osteoporosis. So I don't want to get into too much. I will bring up one thing that might not be brought up is there is a company out of Berkeley that does, it's called On Diagnostics, and they basically, you can send them your CT scan that you already have, and they will apply a finite element analysis to look at stress and fracture resistance. And it's FDA approved, Medicare pays for it in the US, and you can use that as justification if somebody has, you measure their Hounsfield units and you can't really get that to get the medication paid for. You can send this out and then you have another level of verification. I think obviously if you can document the presence of fractures or something, a little subtle end plate thing that you can call and use these things, but it's a challenge. And I think that there's probably a real need and room for us to trial in spine patients, anabolic treatment in osteopenic patients, and they're the people that are cut off. And it's going to be hard, but I think we probably need to get some sort of involvement of some of the pharmaceutical industry to help do that. But I think that'd be something that would really benefit our patients.
Question around evaluating these patients and their neuromuscular component. We've known for years that Parkinson's disease, MS, other neurodegenerative diseases create problems for long constructs. I think frailty there's a neuromuscular component there with frailty that we don't understand, and that I think is a big problem for the elderly. Where do you think we're going to go with that evaluation for going forward? How are we going to think about that?
I think it's huge, and I think the other thing that was brought up briefly yesterday is myelopathy, right? And a lot of our patients want to look down at their feet, even neuropathy, right? Peripheral neuropathy. And there's got to be some sort of functional assessment of cerebellar function or how people want to look and stand. So I think there's probably a neuromuscular part of that. Absolute Parkinson's is like the classic example. I had a patient the other day who was like, 8 centimeters off coronally, just purely coronal. We fixed him and he just can't help himself. That's your inertia concept, right? So how do we assess that? And I think that, the talk yesterday about, assessing thoracic flexibility, that may be a part of it. Assessing motion is going to be probably the most important thing. And, patients' balance and, some of these ways of looking at patients' movement. And we got to find a way to do that really easily. We can't just put everybody with little, balls on them and watch them in clinic. We got to have a good way to do that, readily available.
I totally agree. I think just as there's, the concept of sarcopenia, which is loss of muscle mass, loss of functional muscle mass, there's another concept of cerebellar degeneration, right, which is occurring as you age. And certain people have more advanced cerebellar degeneration as a part of aging that we don't understand. And I think that, it's interesting, I've been in this for a long time. Seg Manish been in this longer than me, but we listen to these PJK talks, right? And not a lot has changed. I mean, if you came to this course, it's 15 years old now, this course, Alekos? If you came to this course 15 years ago, right, and you sat in the back row and you listened to the talks about PJK, and then you listen today, there's not a lot that's different. So part of it is, I think, is this neuromuscular component that we don't understand at all. The other worry that I have is the field of neurology is in a huge struggle at all of our places, right? You can't get a neurology appointment. In my system, there's like 4,000 pending visits for a neurologist, right? And so they have to be our partners in helping us assess this, and that partnership is going to go away just because of lack of access. And so I think it's important for us to understand this. I really want to congratulate you on your point of this talk, which is that we have to own a lot of this. Because we are dealing with aging population. That's where a lot of our adult deformity surgery is.
Rajiv, do you think there's a role for individual departments, orthopedic, neurosurgery, to hire their own neurologists, hire their own endocrinologists, so that you have a little bit more focused treatment?
So the multidisciplinary center of the future is exactly what Alekos is talking about, right? So for example, at UCSF, physiatry lives under orthopedics, which is lovely, right? But you could imagine that if you had a bone health person on your team, right? It doesn't actually have to be an endocrinologist. It could be an APP who is advanced knowledge and is working peripherally with an endocrinologist. We tried to do that at Virginia Mason. We were unsuccessful at doing that. The other area is, hospital medicine. I know of groups that do a lot of complex spine that have their own hospitalist that, comes to their conferences, has, input, right? Part of building that multidisciplinary unit, I'm going to talk about that with the IRIS concept, but is, to your point, bringing all these specialists under our umbrella, right? Because as you know, even with peri-op clearance with anesthesia, that anesthesiologist might not know the difference between an L4-5 fusion and an L4 PSO. It's a completely different ball of wax there. So having specific people who understand complex spine surgery, I think, is a very important component.
Maybe one more question. If anybody has any.
Well, I'll throw it out. Is frailty a modifiable variable?
Well, there's a lot of geriatric scientists that are really trying to look at ways that we can change that. I think from a biological clock standpoint and some of these tissue markers. But it's hard. I mean, I think there probably at some point in the next 10 years will be some ideal medical therapy for that. I think even the concept of, boosting people with growth hormone or something to increase their muscle and, pre-treat them with, exercise to boost them. That might be something. I don't really know if, how much. There's some ideas of maybe like doing multifidus stimulation preoperatively and stuff. I don't know if that's going to get us to that level where it's going to probably prevent the PJF. But there, there's people moving in that direction. A lot of them are way outside of our world. So I think there's definitely research in that area, but we don't really have a lot right now. And honestly, what do you do with sarcopenia other than using it as a decision of maybe assessing how big of a surgery you should do? And I think that that's where a lot of this machine learning stuff will have to go. And Chris often talks about the digital twin. Is it's one thing to have a predictive model that tells you a number and you got a 16% risk of this or 56%. But the better model would be you have a 15% risk if you do this, but a 2% risk if you do that. And that's where the actual implementation of an intervention into the models is going to have to go. We can't just have a model that gives you a number that you're wondering, what should I still do it? Should we take the risk? It's like, no, you should be able to say, well, if we do this, this is what your risk is. And so I think that moving away from just like correlation analysis and stuff in our research, which is always great, you draw these lines between things, but actually looking at, we have all this powerful, machine learning and AI and stuff, like looking at how do we use that to actually test our plan ahead of time to see what the impact of it will be on the outcome. And that's kind of the exciting part, I think, for our field, because we're really close to doing that, but we gotta jump some hurdles to get there.
Yeah, I think Rajiv's point is a really important one as well. Is frailty, we're clumping together vastly different diagnoses. What we need to do is very discreetly cluster the subset with neuromuscular problems, the subset with neurodegenerative problems, subset with muscle bone problems, and the treatments and risks will be very different based on those discrete clusters rather than clumping it all together.
Absolutely.
Thanks again for a wonderful talk. And one of my questions was rate of change. I think baked into all of this as a fundamental assumption is how are things changing? What rate are they changing at? We're not allowed to get DEXs once every 2 years, for example. Even CT scans, if they have like dose reduction protocols, I'm not sure that I can trust the Hounsfield units, particularly next to hardware. So I have a real difficult time making a important judgment about how to take care of a patient that may be frail without having that ability. Are there any tips or tricks or thoughts about that portion, or am I kind of looking in a different direction? Thanks.
I think it's a great point. And even we need a good way to assess our anabolic therapies, right? Are they actually helping? At what point? No one knows whether it should be 3 months, 6 months, a year. Is there a way that we can see where the asymptote is and assess people along the way? We just don't have a good way of monitoring chronologically, changes. But that's a huge need. Absolutely.